Collaboration. Province-wide rounds is a collaboration between the University of British Columbia Division of Nephrology and BC Renal. We're happy to have multiple partners in this endeavor from both industry as well as our health authority partners. And together we endeavor to improve everyone's understanding of kidney diseases and kidney health, best ways to promote that, as well as highlight the work that's going on in the various health authorities. Okay, with great pleasure, I actually am introducing Dr. Vikas Sridhar. He's a clinical assistant professor at the University of British Columbia, a transplant nephrologist, and a recent addition to our group of talented individuals working, educating, and researching here in BC. He's finished his nephrology and transplant training at the University of Toronto and is pursuing a PhD in mechanistic and clinical trials in cardio kidney metabolic diseases, which he's defending in January. He also is a co-investigator on numerous peer-reviewed grants awarded by the Transplantation Society, the CDTRP and KFOC, Canadian Institute of Health Research, Banting and Best Diabetes Center, and the UHN Ajmera Transplant Center and Heart Stroke Foundation. His research interests are really pertinent to all of us and all of our patients, and they include the use of cardio-kidney metabolic therapies in transplantation, as well as the interface of cardiac and kidney diseases in native and transplant kidneys. So with no further ado, welcome, Vic, and looking forward to your talk and stimulating questions and thoughts. So thank you very much.
Thank you, Adir, for the kind introduction and for the opportunity to present the rounds. Good morning to everyone. I'm just going to share my screen. Just want to make sure that. Okay. Adir, you can see. Okay, perfect. So the topic for today is discussing some of our work on repurposing therapies for cardio, kidney, and metabolic protection in kidney disease. And these are my disclosures. And I'd like to start these rounds with clinical cases to tie the work back to the patients that we see in clinic. And I have three cases over here. Number one is a 48-year-old male seen with type 1 diabetes this was a patient we saw in the cardiorenal endocrinology clinic when I was a fellow. This patient, let's just say, had a recent and STEMI within the last 6 months, is on perindopril, atorvastatin, a dual antiplatelet therapy. They have an eGFR of 40 mils per minute and albuminuria of 90 milligrams per millimole. And then case two is perhaps on the other side of the spectrum. It's a 55-year-old female seen for the first time in a general nephrology clinic, referred by their GP with hypertension, does not have diabetes or really any other comorbidities, has an eGFR that ranges around 60 and does not have significant albuminuria. And then case three is someone that perhaps I see in post-transplant clinic. It's a 67-year-old person with end-stage kidney disease. It's now been 18 months since they had a deceased kidney transplant, has hypertension, a history of coronary artery disease, elevated BMI, is on a few medications like aspirin, perindopril, indapamide, and atorvastatin, and usual triple immunosuppression. They have an eGFR 40 mils per minute with really minimal albuminuria as well. And the question that we have for all these cases is, when we see them in clinic, what else can we offer them to modify their risk of cardiovascular and kidney disease in the future? So with that, the topics for discussion today, I'd like to discuss our efforts to studying SGLT inhibition in people with type 1 diabetes. I'll then talk about how we are proposing to evaluate cardio-kidney protective strategies in people at lower kidney and, for that matter, cardiovascular risk. And then finally, talking about evaluating these therapies in kidney transplant recipients. So starting with diabetes, type 1 diabetes is certainly a lot less common than type 2 diabetes, as we all know. However, when you zoom into their risk of morbidity and, for that matter, mortality, there really is a discrepancy between those with type 2 diabetes and type 1 diabetes. And that really it particularly holds true for the development of chronic kidney disease complications and cardiorenal complications, where there's quite a skew between those with type 2 diabetes versus type 1 diabetes. And it actually tends to strike quite early, as is particularly apparent in the panel over here. Despite this, we don't really have too many therapies to offer these patients beyond blood pressure control, glycemic control, as well as RAS blockade. Despite the fact that we've been blessed with all of these new therapies in type 2 diabetes and, for that matter, CKD in general, the translation of those therapies to people with type 1 diabetes is lacking. Now, I'll zoom in on one particular group of therapies, which are the SGLT2 inhibitors. Not to berate the point, but at this point in time, I think everyone on the Zoom call are aware that the benefits of these agents, regardless of diabetes status, on kidney disease progression, cardiovascular death or hospitalization for heart failure, and for that matter, even the MACE composite are quite strong in favor of using SGLT inhibitors. And indeed, they have very much become part of established guideline recommendations for the management of these complications. Specifically focusing on key kidney outcome trials, we have the Credence trial, the EMPA-KIDNEY trial, the DAPA-CKD trial, and as I'll show later, the SCORE trial as well. These are the four major kidney outcome trials that we have demonstrating the kidney protective effects of SGLT inhibitors. But what's important is that these trials universally excluded the following populations, and namely people with type 1 diabetes, anyone on immunosuppression, and end-stage kidney disease as well. So we already have a lack of evidence on cardiovascular and kidney protection with SGLT inhibitors in these populations. So that being said, there actually is clinical evidence for the use of these agents in people with type 1 diabetes. A lot of early work was done with all of the agents, with sotagliflozin, with dapagliflozin, with empagliflozin, on mostly glycemic effects in people with type 1 diabetes. And I'll focus on the inTandem trials. This was a large program composed of the inTandem 1, 2, as well as 3 trials, each of them having, the combination of them having almost 2 to 3,000 individuals. Once again, glycemic endpoints. But some early work done by Dr. Cherney and Dr. Van Relt in 2019 did evaluate some of the kidney effects in people with type 1 diabetes. And what you can see over here in the top left panel is this characteristic eGFR dip that is acute and reversible on cessation. And I'll come back to that point in the next slide. But also you can see acute and sustained blood pressure reductions. Among those with baseline albuminuria, there were albuminuria reduction effects, and there was a rise in hematocrit as well. Now, what are the significance of these markers? So we know from mediation analyses in type 2 diabetes populations with respect to kidney and heart failure outcomes that changes in weight, changes in uric acid, changes in blood pressure, UACR, and actually mostly hematocrit were very much associated with the beneficial cardiovascular and kidney outcomes. So what we did in this study that was published in 2023 was we looked at the inTandem study in people with type 1 diabetes, and we actually evaluated the effects of those markers that were associated with mediation in other populations, mediation of cardiovascular and kidney protection in other populations, and we looked at the effects in the inTandem study. And what you can see universally across these outcomes, with the exception of ACR, that compared to placebo, sotagliflozin did result in weight reduction, reductions in uric acid, blood pressure reductions, as well as an increase in hematocrit, which have all been associated with protection. We didn't really see a significant change in UACR, but as I highlighted, this wasn't a higher risk population with a lot of baseline albuminuria. So with that, we switched gears and looked at the ability to predict cardiovascular and kidney protection with SGLT inhibitors in people with type 1 diabetes based on some of that early work. And what we did was we looked at estimating equations. Turns out there are actually a number of these equations the Scottish Diabetes Research Network, that's the SDRN, as well as the Steno Risk Engine, which have been validated in people with type 1 diabetes to predict cardiovascular risk at 10 years, as well as end-stage kidney disease risk. And these are simple equations. You can actually go to these websites, plug in a variety of variables, and actually get a sense of 10-year risk and 5-year risk in a model that's been validated exclusively in people with type 1 diabetes. And what we did was we looked at in this particular analysis the DEPICT analysis, which is a program of dapagliflozin in people with type 1 diabetes. We plugged in these values to get a baseline estimate of cardiovascular risk and kidney disease risk. And then we subsequently looked at how this changed at 24 weeks. And what you can see over here, when no matter how you slice it, whether there's a relative change from baseline compared to placebo or an absolute change from baseline compared to placebo, there were reductions in the estimated risk of cardiovascular disease and kidney disease, despite the fact that this actually being a very low risk population due to the nature of the original studies that were used. We performed a similar analysis in the inTandem group, and this time we focused on trying to get a sense of how the changes in estimated risk varies by baseline risk. And what you can see on the line on the top is that when you just look at the entire inTandem cohort, which had about 2,500 participants, there were reductions in the estimated risk compared to placebo with sotagliflozin, as you can see over here, and that was significant. We then looked at how this varied by baseline cardiovascular risk, and we simply just used the estimating equations to divide the cohort into those at low, moderate, and high risk. And what you can see is that as you went from low risk to high risk, there was a progressive increase in absolute estimated risk reductions with sotagliflozin compared to placebo, and that was a significant p-value for the interaction analysis. And similar findings when it comes to baseline risk of developing chronic kidney disease in these people with type 1 diabetes. There was a progressive increase in the absolute benefits as you went from low to high risk. And overall, these two analyses and actually third analysis together did support that the use of these agents is likely associated with estimated risk reductions in cardiovascular and kidney risk. And the point of the second analysis of here does suggest that potentially these benefits are greater in those at baseline cardiovascular and kidney disease risk, which is not a particularly surprising finding. Now, we also wanted to tackle the question of safety. As we know, there was tremendous interest in using these agents in the early days in people with type 1 diabetes, but what we quickly realized was this signal of an increased risk of diabetic ketoacidosis. So we performed an analysis also using the inTandem data, dividing the cohort into those with chronic kidney disease and those without chronic kidney disease. Chronic kidney disease, once again, was simply defined as either having an eGFR of less than 60 mils per minute or having at least microalbuminuria. This wasn't particularly a high-risk cohort. And the hypothesis was that perhaps those with more advanced kidney disease compared to those without would have lower risks of severe hyperglycemia and potentially lower risk of adjudicated diabetic ketoacidosis, potentially due to lower glucosuria, less reductions in insulin, and less ketogenesis. Now, the numbers are relatively small, but what we did indeed find in this paper was that in those with chronic kidney disease, there were lower rates of severe hypoglycemia. And then also when it comes to adjudicated diabetic ketoacidosis, the numbers were extremely small. But what you can see over here is that there perhaps was a hint that rates of diabetic ketoacidosis, certainly distinct rates, were lower in those with chronic kidney disease compared to those without chronic kidney disease. There wasn't really much of a difference in terms of some of the other safety outcomes that we evaluated in this paper. So to summarize what we currently know about SGLT inhibition in people with type 1 diabetes, we know that there are modest A1C reductions. We know that there are blood pressure reductions. We know that there are weight reductions and reductions in the need for insulin from these early glycemic outcome studies. We know from physiologic studies that I didn't present over here that there are, especially in those with baseline hyperfiltration, there are reductions in glomerular pressures. This is some of the seminal work done by Dr. Cherney in 2014. We know that there are potentially neutral effects on hyperglycemia, but we certainly do know that there are increased ketogenesis in people, especially in people with type 1 diabetes. But beyond some of the preliminary work that I presented on estimating equations, we do not know truly about cardiovascular and kidney protection in those with type 1 diabetes, especially in those with more advanced chronic kidney disease, as they were all excluded from these trials. And there remains a very important need for this work to be done. So with that in mind, a few years ago, we embarked on the SUGARNSALT trial. This trial aims to evaluate the effectiveness and, importantly, the safety of sotagliflozin in slowing down kidney function decline in those with type 1 diabetes and more advanced diabetic kidney disease. And like I mentioned, there are two equally important aims. Number one is an effectiveness, and number two is to institute and then assess the feasibility and effectiveness of a DKA mitigation protocol, such that we can not only aim to identify benefits, but also do that in a safe manner. So we aim to randomize 150 individuals to either sotagliflozin or placebo for a period of 3 years, which will be followed by a 2-month washout period. And just very quickly, not all of us may be familiar with sotagliflozin. Sotagliflozin is a little bit late to the party, but they do have an outcome trial, the SCORED outcome trial, as well as a heart failure trial, the SOLOIST worsening heart failure trial. And this was another analysis that we did last year, whereby we actually looked at both case report form outcomes as well as lab adjudicated outcomes. And what you can see over here when it comes to the composite kidney outcome, whether using a 40% decline in GFR, 50%, or a doubling of creatinine with or without cardiovascular endpoints included in the composite, no matter how you slice it, there were consistent benefits in favor of sotagliflozin. Keep in mind, this was a type 2 diabetes kidney outcome and cardiovascular outcome study. Now, coming back to our efforts to study the benefits of sotagliflozin versus placebo in type 1 diabetes, SUGARNSALT is looking to recruit individuals on stable RAS blockade with type 1 diabetes with an eGFR of 20 to 60 mils per minute, and they need to have at least 200 milligrams per gram of albuminuria. We've since slightly relaxed this criteria to have a lower UACR cutoff, provided that they have historical elevations in ACR. And the primary outcome is the eGFR, creatinine, and cystatin C after that 8-week drug and washout. So in other words, we're removing the effect of that acute dip in terms of our primary outcome, and that allows us to just get away with a smaller sample size. Equally important are the secondary outcomes. So we are looking at more traditional kidney composites. We're looking at changes in albuminuria. We're looking at eGFR slope as well as cardiovascular outcomes as well. And this is a little bit old. I think, yeah, this is from October. The study is currently recruiting. We're making good progress, and I do want to thank everyone that has reached out and recommended patients for the study. Please email me or Adira after this if you do have anyone that you feel would be a good candidate for the study, as this is something that will be an outcome study and will likely lead to indication if successful. So coming back to our case of this 48-year-old gentleman with type 1 diabetes that we see in clinic, this is someone that we would refer to the SUGARNSALT trial. So that's one thing. The remodeled T1D study is also evaluating semaglutide in these individuals. And then very exciting, this is hot off the press, we do actually have preliminary results that were presented last week at Kidney Week on the FIND-1 study. This hasn't been published yet, but the FIND-1 study did demonstrate significant acute and sustained reductions in albuminuria over 6 months. And this is something that I do anticipate will lead to changes in practice, and it's very exciting. So now that we've talked about type 1 diabetes and perhaps the higher end of the risk spectrum, we're also interested in evaluating some of these agents in lower kidney risk patients. And this is a figure which was published a few years ago at this point in time, proposing the model of a CKM staging, where you have stage 0 without risk factors, stage 1 primarily characterized by excessive or dysfunctional adiposity, stage 2 being more your increased metabolic risk, and this is when they introduce chronic kidney disease, And then stage 3 and stage 4 is when you go into your more overt disease. And chronic kidney disease very much also plugs into more advanced stages. And I just wanted to highlight a few things over here. So number one, in stage 2, where they include moderate to high risk chronic kidney disease, they do refer to the CKD heat map. And I think it's important to realize that even when you go, first of all, when you go look into the KDIGO heat map, we certainly have evidence for a lot of the therapies that I've discussed in the higher range of this risk, but in some of the stage 2 to stage 3 CKDs, especially in those without albuminuria and those without type 2 diabetes, we are lacking evidence for some of these therapies. And the other thing I just wanted to highlight was with the introduction of subclinical heart failure into stage 3, it did demonstrate interest in looking at biomarkers associated with subclinical heart failure and BMP and the associated cardiovascular risk. And what we were also interested in is the associated kidney risk. So while the model, the framework of CKM was introduced fairly recently, several years ago, we were also very much interested in evaluating the mechanistic effects of SGLT inhibitors in individuals at low to moderate cardiovascular risk. And with that, we had designed and we conducted the DAPA suite study. And this was a mechanistic study where we took 51 individuals at quote unquote increased cardiovascular risk with and without diabetes, and they were randomized to dapagliflozin or placebo for a period of 12 weeks. And we had a baseline visit, we had a 1 week visit, and we had a 12-week visit where we did a number of mechanistic outcomes, trying to demonstrate how these agents work in these patients. And the way we defined increased cardiovascular risk, we looked at individuals with and without type 2 diabetes. And if they were on the younger side, above 50 years, they had to have one cardiovascular coexisting condition, either coronary disease, stroke, or peripheral vascular disease, or heart failure. And if they were older, above 60, we accepted cardiovascular risk factors. They need to have at least one of either LVH or microalbuminuria or LV systolic or diastolic function or an abnormal ABI. And this is the baseline characteristics. Roughly half of these individuals had diabetes. A significant portion of them were on baseline RAS blockade. This was not a cohort with particularly advanced chronic kidney disease, as you can see with the mean GFR, nor were they a particularly albuminuric cohort. And actually, when you slice up this population, it very much falls roughly half of the cohort that we studied would not currently meet indication for agents like an SGLT2 inhibitor, and the other half would meet. So we had this nice dichotomy of the patient population. And the results, which are currently under review for publication and were presented in poster form at Kidney Week recently. So our primary outcome was arterial stiffness, which is a surrogate for cardiovascular outcomes in large populations, including in chronic kidney disease populations. So as you can see over here, we looked at both the aortic augmentation index and pulse wave velocity. We're actually able to measure this in the lab using a tonometer to get a sense of these variables. And what you can see over here is that with respect to aortic augmentation index, there was a significant reduction by week 12. We did not see this for pulse wave velocity. We looked at a number of secondary outcomes this year as well. And what you can see over here is that there was an acute and sustained dip in measured GFR. There was a very consistent acute and sustained natriuretic signal, whereby we looked at fractional excretion of lithium as a surrogate for proximal tubular sodium handling. And then we also looked at apologies, this picture is a little bit small, but we also looked at body composition changes. And as you can see over here, there are acute and more sustained changes in extracellular fluid, extracellular estimated plasma volume, as well as changes in total body volume. We then wanted to look at evidence of crosstalk between proximal tubular sodium handling, in other words, the natriuresis, and the observed dip in GFR. So we looked at evidence of that crosstalk, and we looked at changes in adenosine, specifically urine adenosine, which is believed to mediate some of that tubular glomerular crosstalk. And we do indeed see that there were significant changes in adenosine with dapagliflozin versus placebo, suggestive of this being intact. We also looked at clinical outcomes. We looked at changes in blood pressure, which did not quite meet statistical significance, though there were within group reductions in blood pressure with dapagliflozin. We also looked at BMI, and as you can see over here, there was both an acute and more sustained change in BMI, consistent with some of the volume effects that I demonstrated in the previous panel. And all of this was accompanied by RAS activation as well. So what we ended up concluding in this physiologic study that dapagliflozin elicited physiologic changes that were relevant to cardiovascular and kidney risk. And importantly, when we did evidence of interaction, granted this is a small population, between those individuals with and without diabetes, or between those individuals that would clinically meet an indication for an SGLT2 inhibitor or not, there really was no evidence of heterogeneity, which does lend mechanistic support, we concluded, for potential early protective effects of these agents in participants at varying levels of cardiovascular risk, in whom current clinical evidence of protection is lacking. So now that we have demonstrated in the previous trial that the mechanistic effects of SGLT inhibitors are present, we're interested in how to actually identify some of these individuals that on paper may be lower risk, but may actually be at high risk of developing future kidney and, for that matter, cardiovascular complications. And one strategy we looked at was more of a biomarker-based strategy. This was an analysis that we did of the SCORED trial, where we looked at the association of subclinical heart failure. And subclinical heart failure in the 2022 AHA heart failure classification now incorporates cardiac biomarkers to actually define individuals at risk of heart failure. And they do that by defining these various stages. So stage A heart failure, just people that do not have symptomatic heart failure, they have normal cardiac biomarkers, and they define that as having a NT-proBNP of less than 125 or a high sensitivity troponin of less than 14, and they needed to have normal cardiac structure as well. Now, stage C or D is more overt symptomatic heart failure, but we were particularly interested in stage B or pre-heart failure. These individuals without overt heart failure, they can even have completely normal echocardiography, but they have low-grade elevations in NT-proBNP and troponin. And what we did over here is that we applied these criteria to the SCORED trial, which, just to remind everyone, was a trial that was a cardiovascular and kidney outcome trial in individuals with type 2 diabetes and diabetic kidney disease. And I'll first direct you to this, just focusing on the MACE panel above. What you can see over here is, unsurprisingly, as you moved from stage A to stage B to stage C, so in other words, more overt heart failure, there was an increase in the placebo risk of events of MACE, and for that matter, cardiovascular death or heart failure. What was interesting is that having these biomarkers suggestive of pre-heart failure compared to normal, the stage A individuals without overt heart failure, that also predicted the risk of kidney disease progression. And it wasn't that different between stage B and stage C or D, which is the more overt heart failure. And then, of course, when you go look at the effects of sotagliflozin versus placebo in this particular analysis, there was evidence of benefit with sotagliflozin in the cohort as a whole. But also when you slice it and you go from stage A to stage B to stage D, there was evidence of benefit with respect to kidney disease progression, the cardiorenal composite, as well as some of the more cardiovascular outcomes. And our conclusion from this is that the use of these biomarkers, NT-proBNP and high sensitivity troponin, even at low levels, is associated with, number one, the risk of kidney disease progression, and may also identify people that can benefit from these agents. Moving from a biomarker-based approach, we're also interested in physiologic risk assessment. And this is something that Adira and I have talked about a lot, and it's something that we're very interested in. And that is the concept of the renal functional reserve, and trying to identify who has intact renal functional reserve and who doesn't. And just this figure over here, I'm a big fan of this figure. It just demonstrates the concept that as you lose nephron mass, as disease progresses, your baseline GFR can be mostly unchanged, especially as you go from 2 million nephrons down to, approaching 500,000 nephrons, your baseline GFR does not change much. But when you apply some sort of a stressor to identify renal functional reserve, and that typically is a protein load, which leads to an increased GFR via preglomerular vasodilation, and that's typically observed roughly 1 to 2 hours after your protein load, you get this very characteristic rise in the GFR. However, as you lose nephron mass, you have less and less ability to recruit that GFR, and you get less and less of a rise, or in other words, a blunted renal functional reserve, suggestive of an impaired adaptive capacity, despite the fact that on paper, when you go look at these individuals, their GFR may be completely fine. So in other words, you can design what's called a renal stress test, and this is a physiologic-based risk assessment. And there's been some work done. Many people have done a lot of work. This is not a particularly new concept, but in light of all of these new therapies, our Dutch colleagues actually conducted a study over here. And as you can see, it's a bit of a complicated design, but just to simplify things, they looked at these individuals, they kept them in the lab for almost the entire day, and they had a continuous infusion of both iohexol and PAH. And at the same time, they were able to collect urine collection to get a sense of measured GFR. And then they actually applied a protein load. In this case, it was just like a protein shake. And then they were able to observe changes in GFR over time. And then they were able to repeat these analyses with the administration of an SGLT2 inhibitor. And this study was looked at several outcomes, but what I really wanted to highlight was that they found a very nice correlation between the renal functional reserve and the dip associated with an SGLT2 inhibitors. And specifically, what they noted was that a blunted increase in GFR, so in other words, that impaired adaptive capacity after the protein load, which would be suggestive of reduced renal functional reserve, and therefore single nephron hyperfiltration, despite having normal or similar baseline GFRs, was very strongly correlated with a greater drop in the GFR after 8 weeks of treatment with empagliflozin. Now, and so that's interesting. You may be asking, what is the significance of this dip? And the answer is, turns out that the dip associated with agents like SGLT2 inhibitors, and for that matter, even RAS blockade, is very important. So this figure, the panel on the left over here, I'm sure many of us have seen this, that when you start agents like SGLT2 inhibitors, there is this very characteristic acute dip, and that is usually followed by stabilization or certainly a reduction in the rate of decline in GFR over time. Apologies. Compared to the placebo group, which continues to decline. Now, when you do analyses whereby you look at the association between this dip, whether or not you have a greater dip versus a smaller dip after treatment with an SGLT2 inhibitor, this particular analysis was actually conducted with a RAS blocker, so it's a very old analysis from 2011. What you find is that the greater the dip is more strongly adjusted with a subsequent slower reduction in the rate of GFR decline, and has been demonstrated in some of the more recent analyses with SGLT inhibitors, is associated with slower rates of the kidney composite outcome. So we do know that that dip, which likely is suggestive of activation of renal protective mechanisms with these agents, is associated with subsequent kidney protection. And what is very interesting is that we are able to correlate that loss of renal functional reserve with that dip effect. Because what we don't really have is a lot of long-term follow-up on the effects of loss of renal functional reserve with subsequent kidney outcomes. There are some interesting analyses with respect to AKI. So this was a particular study that was done in individuals with preserved GFR, albeit with other comorbidities, and they looked at the risk of developing acute kidney injury after cardiac surgery. And what you can see is that when they went back and did this retrospectively, individuals that had lower renal functional reserve compared to those that had more preserved renal functional reserve, those individuals had a much higher risk of developing AKI after cardiac surgery compared to those that had more intact renal functional reserve. So when it coming back to our case, this 55-year-old female seen for the first time in general nephrology clinic, that seems to be, for the most part, apart from a GFR of 59, does not have a large number of comorbidities, how do we identify the individual that is at much higher risk of progressing, that perhaps we treat more aggressively with some of these new agents versus someone that is more likely to just maintain their kidney function? Two strategies that we've highlighted. One may be the use of biomarkers, and the other one may be the use of a renal stress test. Perhaps one day we order a renal stress test to risk stratify these individuals. Now, this is research that very much needs to be, the line of investigation needs to be pursued to establish these connections. And it's something that me and certainly Adira have talked about a lot and are quite interested in pursuing. So now I'll wrap up by talking about the use of these agents in kidney transplantation, a clinical area that's very near and dear to my heart. So there remains an extremely strong need for new cardio-kidney protective strategies in kidney transplant recipients. The primary cause of late graft loss remains recipient death with function. Roughly 50% of these losses are death with function. In other words, they have functioning kidneys, but they die of cardiovascular disease most commonly. Or many of these individuals do also just have non-immune progression of renal function, progressive decline in their renal function. That being said, like the type 1 diabetes population, we don't necessarily have a translation of many of those benefits to the kidney transplant population. And that also led to our interest in studying the mechanisms of SGLT inhibitors in kidney transplant recipients. These patients are physiologically somewhat unique. We are dealing with a denervated kidney with loss of sympathetic innervation. We're dealing with a single kidney rather than two native kidneys for the most part. So it's a very unique population that has led to concerns on the use of these agents and perhaps slower uptake of these agents compared to other patient populations. So like the DAPA Suite study that I presented earlier, we also wanted to evaluate the mechanisms of SGLT inhibitors in kidney transplant recipients, and that led to the Infinity study. It's a very similar design to the DAPA Suite study in that we had 52 kidney transplant recipients that were stable. They either had diabetes, they either had diabetes or not, and they were randomized to dapagliflozin versus placebo for a period of 12 weeks. There was a baseline visit, there was a 1-week visit, and then there was a 12-week visit as well. So once again, to reiterate, stable patients with a GFR of at least 30 mils per minute. In this particular case, we looked at blood pressure reduction just based on the data that we had, some of the preliminary work that we had done at the time of writing this grant. We also looked at many of the secondary outcomes that I described in the other study, and we also did a biomarker analysis as well. These results are also currently under review and were presented at Kidney Week recently. Our primary outcome was blood pressure, and what we were able to demonstrate was a significant reduction in mean arterial pressure that was apparent at 1 week. However, there was actually a lot of interesting data generated in terms of our secondary outcomes. So like DAPA Suite, you see this acute dip in iohexol measured GFR that was present by 1 week and was sustained at 12 weeks. Unlike DAPA Suite, which was a native kidney disease population, and in other studies, there really wasn't this signal of natriuresis, and that was total natriuresis by looking at FENA. We also looked at proximal natriuresis with feli. We looked at the difference, looking at distal. No matter how we looked at it, we just were not able to demonstrate evidence of natriuresis, despite the fact that the sample size was identical. Like many of the studies that we've done have very similar sample sizes. Most of them demonstrate this acute natriuresis, but we did not demonstrate that in this particular study with kidney transplants, which we thought was interesting. And this is despite there being quite a robust glucosuria and an increase in urine volume. We did not see this change in proximal tubular natriuresis, or for that matter, total natriuresis, which we found to be interesting. Whether this is a smaller effect size and we just were inadequately powered, could this be due to the use of baseline CNI therapy that perhaps led to these lower than observable rates of natriuresis? We also try to look at changes. We try to look at evidence of tubular glomerular feedback by looking at correlations between glucosuria and feli, and we did not really demonstrate anything over there. We looked at arterial stiffness, which was neutral in this particular study. which was significant in DAPA suite. There were acute changes of BMI, which is supportive of a volume effect. We even looked at adenosine. I did not include that in this particular slide, but adenosine wasn't significant as well, where it was significant in the other study. So this is all very interesting because it suggests that yes, there is a GFR dip, but we're not seeing that classical natriuresis, which very much begs the question: will these agents work in the same way with respect to cardiovascular and kidney effectiveness in transplanted recipients compared to native population? And I think that's a very important question because I think there remains equipoise for the use of these agents in this patient population. And I'll talk about our efforts to investigate that shortly. We're also very interested in evaluating GLP-1 receptor agonists in kidney transplant recipients. There's really been a proliferation of these agents. It was not too long ago that we were talking about semaglutide and the FLOW study after all the cardiovascular outcomes. But now we've moved on to agents like tirzepatide with 2G therapies, and now we even moved on to triple G therapies, and there are so many outcome trials. And once again, individuals with a kidney transplant, and for that matter, type 1 diabetes, have all been excluded from these trials. So we're interested in a mechanistic evaluation of semaglutide in kidney transplant recipients, specifically from the lens of preventing post-transplant diabetes. Now, we know from a number of studies across agents that the use of GLP-1 receptor agonists, incretin therapies, do prevent diabetes, to prevent the development of diabetes, and particularly those in risk. And this has been demonstrated in some of the older trials in the SCALE program as well as in the STEP 5 analyses. And we subsequently designed the SPOT-DM study. We're looking at 24 individuals randomized to oral semaglutide versus 24 randomized to placebo. We're following them for 24 weeks. And this study will be powered around a change in blood glucose, so a 2-hour oral glucose tolerance test. We'll do that at baseline and we'll do it at follow-up. But we're also looking at a number of secondary outcomes. We're looking at a biomarker analysis as well, and we've also incorporated multiparametric MRI as well, with the goal of looking at changes in kidney volume, changes in hypoxia, fibrosis, a number of changes in renal sinus fat. So this is I'm very excited by this study, as it's going to give us a lot of mechanistic insights in a quite a novel population with a single kidney physiology, in a patient population that's at risk of a lot of these adverse events. And what's particularly novel is we're looking at this quite early post-transplant as well. And finally, I'd like to talk about our efforts to actually conduct an outcome study in kidney transplant recipients. Now, there are a lot of challenges to planning cardiovascular and kidney outcome trials in kidney transplant recipients. You need a large N traditionally to achieve adequate power to detect primary clinical endpoints. A lot of the studies that I've talked about, the EMPA kidneys, the DAPA CKDs, the SCOREDs, these are thousands and thousands of patients. The largest transplant study that's ever really been conducted to date is the Elite Symphony study, and that had just 1,645 patients. Outcome definitions, therefore, become very important. The traditional composite outcomes are likely not going to fly. You're going to need to incorporate composites of cardiac and kidney allograft outcomes. And likely this will need to include percentage declines in GFR as in traditional outcomes, but also a role for GFR slope. Now, we know from studies in the native kidney that percentage declines in GFR are associated with adverse kidney outcomes. And this is some of the seminal work performed by Koresh et al., published in JAMA in 2014, which very much altered the landscape of these kidney outcome studies. And in this study, they were able to demonstrate the evidence that your 40%, 50% changes in GFR were associated with subsequent hazard ratio for the development of end-stage kidney disease. Granted, as you had larger and larger percentage changes in GFR, this became less and less common. In other words, you would need more outcomes to actually, these outcomes occurred less frequently, and therefore you need a larger sample. Now, we actually have this evidence in kidney transplant as well. And this was published in JASN at this point in time several years ago, where once again you were able to demonstrate the exact same thing, that even in kidney transplant recipients, changes of 20% and 40% for that matter were associated with quite significant increase in the subsequent risk of patient death, graft failure, and death-sensitive graft failure. So a very similar pattern to what is observed in native CKD. A lot less is known about GFR slope. Unlike studies performed by the CKD Epi Consortium in native kidney disease, we know a lot less about GFR slope as a surrogate outcome in transplant recipients. So we are currently quite advanced in evaluating, in designing and planning an outcome study of SGLT inhibitors in transplant recipients, and that's in the Renaissance trial. So Renaissance has been designed to be relatively pragmatic. At this point in time, we're looking for individuals with a GFR of above 20. They need to be stable post-transplant. And the way we have designed this particular study is with a hierarchical primary outcome. And this is a major adverse cardiac and kidney outcome. And the way this is designed, as opposed to a traditional composite outcome, we've actually incorporated this pyramid scheme where you have all-cause mortality at the top, which is less frequent, and as you go down, you have more and more frequent outcomes. So allograft loss, stroke or non-fatal MI, and then we have sustained 40% declines in GFR, heart failure events, and then finally we have incorporated the continuous variable of eGFR slope. And the idea over here is that the sample size is derived by what's called a win-loss ratio. And what we do over here is that we compare in the sample every patient in the trial with every other patient in a pairwise manner. And we work our way down this pyramid. So what we first do is that we look at every possible combination and see if one patient in the pair survives longer than the other. And that's the all-cause mortality endpoint. And if one does, that person is declared the winner. If neither participant dies over the follow-up, then we move down to allograft loss, and we see if one person has allograft loss versus the other. And if neither person in the pair, in every possible combination pair, experiences that event, we move down this pyramid. And ultimately, as a tiebreaker, we can always use a continuous variable of eGFR slope. And this method is advantageous over the traditional time to event analysis in two ways. Number one is that it actually incorporates what our patients feel is important, and we did incorporate our patient partners in terms of the selection of these endpoints. And it's also better than your traditional time to event analysis in the sense that it accounts for event importance. So in a traditional time to event analysis, you would be considered as having an event if you have a heart failure event in the same way as whether or not you had death. But in the hierarchical composite outcome, all-cause mortality is judged to be more important than a heart failure event. And that's why it was very important to get that clinical and patient feedback as well. The other major benefit of this is when you incorporate eGFR slope as a tiebreaker, you're able to get away with a lot smaller sample size, as you can see over here. So this is illustrated in the Credence and DAPA CKD study. When you used your traditional primary endpoint, to get a power of 90, you needed a much larger sample size, and you're able to drop that down when you incorporate a hierarchical composite endpoint with eGFR slope. You're able to significantly reduce the required sample size from 1,500 to reach statistical significance all the way down to less than 500. So it very much gives us a power advantage in designing these studies and allows us to get away with a much smaller sample size. So we incorporated that and came up with a sample size of 900 participants. So we're actually trying to get funding for this via the U34 U01 NIH funding mechanism. Our U34 grant was positively reviewed, and we did get funding for an RCT planning application. And we are hopeful that we will then be able to leverage this to add the actual U01 grant to fund the study as a whole. So with that, coming back to our case of our 67-year-old gentleman seen after 18 months after transplantation, I think this is the perfect candidate where we have equipoise for the use of SGLT2 inhibitors and would be an excellent candidate to be included into the Renaissance trial. And with that, I'd like to conclude. I'm happy to take any questions, but I also wanted to acknowledge everyone that has been involved, the members of my thesis committee, including my supervisor, Dr. Cherney, members of the renal physiology lab, and all of our collaborators and funders as well. Thank you.
Thanks for incredibly comprehensive. Maybe stop sharing so we can see, but thank you so much for really stimulating our thoughts around not just, what we can do for patients before and after transplant, but also highlighting that, the sophistication of what we can measure um, is improving. And I think that was quite interesting. Are there questions from the audience? I see it. Hold on. There's 4 Q&As. So one of the questions is, uh, can we use sotagliflozin in type 1 diabetes yet?
Yeah, I could. I mean, at this point in time, I would the SGLT any SGLT inhibitors are currently not recommended for the use in individuals with type 1 diabetes. I think there's equipoise and the studies need to be done. Sotagliflozin is currently is not available in Canada. It is available in the US, but not yet in Canada. So I would say we're not using these agents in people with type 1 diabetes. But if you have anyone with albuminuria and you think would benefit from these agents, please refer them to us. You can either email me or Adira, and we'd love to get them in a trial.
So we are so we are involved in the sugar and salt study. So yeah, we have the ability to allow people to participate in an RCT. So we don't know whether they get active or inactive drug, but I think that is a value. I do know that some of the diabetologists in their stable diabetics who are well informed have begun to use some SGLT2s, but again, it's totally off label. And as you said, there's no data. So we really do need to put people into trials.
Yeah.
So
And
there's
then when you do ask patients, I mean, patients understand the risk benefit of these equations and, they're quite informed.
And in fairness, and correct me if I'm wrong, but no DKA event ever occurred in the absence of an acute illness. I mean, they're not um, it doesn't just happen that you get DKA. It has to be because there's an inciting event.
Yeah, or stopping insulin.
Yeah, which is an inciting event for
Yeah.
ketoacidosis. There's a question about whether or not there's a stage of decline where you wouldn't start an SGLT2. And and then another question is, does the renal stress test carry any risks? I think that's a great question.
Yeah, so yeah. So in terms of stage of decline, so we currently are not so if you're on an SGLT inhibitor that was initiated earlier on in their progression of their kidney disease, typically our practice is to continue it until initiation of dialysis. The EMPA kidney study, they actually continued it after dialysis. I do not start it in individuals with a GFR of less than 20. I think that's quite common practice. Um, this question will be answered hopefully in the next year or so with the renal life cycle study. The renal life cycle trial actually has 3 cohorts. One cohort is individuals with much more advanced chronic kidney disease, well below 20. The other cohort is individuals with on dialysis but with residual kidney function. Then there's a transplant study as well. So currently, I would say less than 20 to not initiate. Um, The next question about the renal stress test in more advanced kidney disease. Yeah, so that's a great question. We certainly do talk about avoiding hyperfiltration in those with more advanced kidney disease. We don't like renal stress tests are not conducted frequently, but I would argue that this is just a single protein load. Uh, it's just a very distinct event. So I would feel comfortable doing it in more advanced kidney patients. However, I think the real benefits are those and not with more advanced kidney disease. In those with more advanced kidney disease, we already know that they've lost their GFR. Their regular unstressed GFR is already falling. There's already a lot of evidence for the use of these agents in those patients. So we know that those patients have already lost renal functional reserve. They already have single nephron hyperfiltration. The utility of performing a renal stress test in those patients is probably less clear. I think the utility is much more in people with normal kidney function. They come to our clinic, they have a GFR of 60, and we're not really sure are they going to progress or not. The other point that Adir and I have talked about is someone that has recovered from an AKI. Does everyone that has recovered from an AKI and now has normal kidney function, are they the same? Even if there may be two individuals that had an AKI and they now have a GFR of 75 without albuminuria. Perhaps one of them has a complete loss of renal function reserve and the other one doesn't. So I think the utility of these stress tests is more in those lower risk cohorts based on our traditional measures of GFR and albuminuria. I've certainly had conversations with Dr. Elliott as well in his genetic cohort. So I think there's a lot of applications. It's probably like a single stress test in someone with more advanced kidney disease is probably okay. I just think the utility is a lot less because we already know that an individual with more advanced CKD is at high risk of progressing and probably does need to be treated aggressively.
Yeah, I think just to amplify what you're saying, I think that if you think about nephrology and you think about other subspecialties that have dynamic testing of their organs that help inform care and everything else, I think we've settled for static measures, plain old ultrasound, plain old MRI, and the value of maybe normalizing or making more available standardized renal stress testing so that we understand more about an individual, not just their GFR. I think that's where the value is, and we just need to figure out, how to do this in a more accessible fashion, no matter where you are. Just final question from Dave Nickel: which transplant patients are you using SGLT2s in currently?
Yeah, it depends when you ask me. So I think if we so Dave, you and I have talked about this before, but we're hopefully close to getting this trial off the ground. And I would argue, like in the type 1 diabetes population at this point in time, if we truly have equipoise, and perhaps I hope some of the data that I presented lend it to that equipoise, we should really, really try to get them in a trial. Um, if they can't get into a trial, my framework is for cardiovascular, specifically for heart failure outcomes and established ASCVD in those with diabetes, it makes sense. Where I'm not using them is kidney protection. But I think at this point in time, if we do, it looks like we'll get this trial off the ground. You know, I think this should be formally addressed in the setting of a trial. So my answer is perhaps slightly changed the last time we talked about this. And I think that's because we have trials that we can offer our patients that can very much answer, hopefully address the equipoise that I have in using these agents.
Yeah, I think that's a wonderful note to end on because I think, there's so much excitement in the kidney world about all the things we can do. And we have to cultivate this culture of, if you don't know the answer, let's get people into trials and let's answer it properly so we don't have, eminence or opinion-based nephrology, because we've just come out of that era and we now have all these great things, and let's get people into the trials. And we can talk another time about, maybe platform and basket trials where we're looking at ways to have a similar protocol, no matter whether you have one kidney or two kidneys, a transplant or a non-transplant, and think about how we can test these things. So again, thank you very much for an incredibly stimulating and thoughtful talk, all the work that you've done and will continue to do, and stay tuned for answers to important questions. So thanks everybody for your participation, and Vic for preparation of an excellent talk.
Thank
Thanks.
you.